Hello, everybody, and welcome to this episode of Pharmacy in Phlux. I'm your host, Derek DeRosier. My co-host, Phil Hauser, is taking a day off today, so I'm flying solo in this episode. But I've got two fabulous guests today to talk to us about a very current and sensitive subject, I think. Our first guest is Mona Kwong. Dr. Mona Kwong is a pharmacy advisor and director of the Addiction Pharmacy Fellowship at the BC Center on Substance Use. She continues to practice pharmacy as a clinical pharmacist at the Infinity Medical Specialist Clinic and as a managing partner at the Howe Street Pharmacave. Mona is an experienced instructor, mentor, preceptor, and she has shaped the minds of careers of many pharmacy students as a clinical instructor and preceptor. And I can certainly vouch for that. I've known Mona for many, many years, and I know she's had a long and distinguished career in pharmacy, and we're really glad to have her on board. So welcome, Mona. Our other guest today is Guy Felicella. Guy's a passionate advocate for the vulnerable people who suffer in addiction. He spent nearly his entire life suffering from the same disease, and now he educates communities on harm reduction through public speaking to eliminate the stigma that exists around it. Guy is a peer clinical advisor with the BC Center on Substance Use, and he's started a career with Vancouver Coastal Health and the Ministry of Mental Health and Addiction, in addition to attending various school districts to help educate students about addiction. So welcome, Guy. So let's talk about what's going on, and there's been a lot of stuff in the news. So here we are, and yesterday we just heard, so setting the stage for the discussion we're going to have today about safe supply guidelines and resources available for opioid agonist therapy and folks who need those kind of resources, and a number of other sort of policy and legislative issues around that. And we'll kind of see where the discussion goes. But to set the stage, we heard yesterday in a report by the BC Coroner Service that May of 2020 saw the highest number of overdose deaths in the province of BC than ever before. And we've had a public health pandemic of opioid overdose deaths declared in this province for a number of years now. And it doesn't seem to be that some of the initiatives are having the kind of effect that perhaps government wants them to have. For a number of reasons. And I think we want to explore some of those today. We want to explore the safe supply guidelines that have come into effect and how that all relates to the COVID pandemic that we're also trying to navigate at the same time. So let's kind of start with that. And Mona, I'm going to ask you initially, if you can just give us the sort of Coles Notes version about these safe supply guidelines and
Sure.
What are they and what are they intended to achieve?
Well, new guidelines came into place, and they're actually meant to mitigate and reduce risk because, as you mentioned, the two public health emergencies, basically the overdoses emergency, which has happened for the past 4 years. It got announced 4 years ago, and then the recent COVID-19. So basically, they provide advice to prescribers as well as pharmacists on supporting people who use drugs to self-isolate and avoid the toxic, poisonous street drug supply that's gotten more dangerous during the pandemic for sure, and you can see that with the increase in numbers this month.
So moving from there, Guy, let me ask you this, because I'm personally, and even as a pharmacist, having trouble wrapping my head around this. So I guess a couple things. First, is it your perspective that the increase in overdose deaths that we're seeing is related to the increased toxicity of the street drug supply, and is that in part due to supply chain issues that are related to the COVID pandemic, or is it related to the fact that people who are using these drugs are using them in a more alone than they maybe have in the past because of a fear of contracting COVID-19 if they're not social distancing and self-isolating? Or is it both?
Yeah, I think it's a combination of things. I don't think it's any one set thing. I think it's everything. And also too, just because the contaminated drug supply is so unpredictable as it is, the federal government cannot regulate what drugs make it into this country, and they can't control what toxicity levels are put in the drugs. And obviously, with everything going on since 2016, even before COVID-19 came into place, we were already in a public health emergency. And the reason why it's just that unpreparedness of and not expecting COVID or not understanding that, nobody could predict COVID was happening. It shows just how far little we had done to address it.
Yeah, I can certainly appreciate that, and as evidenced by the emotional state of our provincial health officer, Dr. Bonnie Henry, when she announced some of this in her media briefing yesterday, and it really does hit home. And so help me wrap my head around this, Guy. I'm struggling with the idea that users of street drugs are less fearful of dying of an overdose than they are of contracting COVID. It seems that that's the case for many people, and I just I don't know how to rationalize that in my mind.
Yeah, well, I've been through, I was through this is my second dual public health emergencies I've lived through. First one was HIV and the overdose crisis in 97, where the overdose crisis took a backseat to the HIV crisis. So I was also in the downtown east side when this outbreak of the swine flu was rampant everywhere. And then the one thing that you have to understand is that withdrawal waits for no one. I already have a dependency to heroin. I might get COVID. It's more concerning for me to address my dependency to heroin or fentanyl or whatever it is. And yeah, COVID really isn't a threat to drug users in a sense that um, over their substance use disorder or opiate use disorder. So drug users are going to have to do whatever they can to avoid withdrawal. And whether that's, if COVID's in the way of that, that's not going to stop. That won't stop any user from having to do what they have to do to get their substances. So.
Okay, fair enough. So Mona, how do we address the naysayers that say that these kinds of safe supply guidelines and being a little bit more liberal with providing access to a safe supply is just enabling a problem to persist and get worse? It's certainly not my perspective, and shouldn't be the perspective of any healthcare professional, but it's certainly the perspective of some segment of the public. And what's from your perspective the way for us to address those kinds of issues?
I think it's a broader picture because it goes back to the war on drugs. It really basically it's decriminalization and also the legalization that needs to be looked at. Basically, legalization of illicit drugs would shift the control of that drug supply from the organized criminals who have profited immensely, right? So that is the balance that we need to be looking at and thinking about instead of having a problem for some of the naysayers.
Yeah, so at some point we probably need to come back and revisit that, and maybe have another um, episode of the program here where we talk a little bit more about broader policy and potential legislative changes that would either decriminalize and or make it even much easier to provide a safe supply to those who need it. So in terms of the guidelines that we have now, these new guidelines from BCCSU, are these guidelines so let me put it this way. Did these guidelines come about as a result of trying to help people have access to a safe supply in light of the COVID-19 pandemic, or were they completely, was the COVID-19 pandemic irrelevant to the issuance of these guidelines?
It's always been in the underlying look at things because this is only one model for safely regulating substances. Because we are in such a dual public health crisis and we're looking at it from a public health approach, we need to regulate a safe supply while really increasing access to treatment and recovery as best as we can right now because people need that access point. There is not enough. There's a drying up of some of the illicit drug supply out there, and for users, it is very hard when they're going through withdrawal.
Okay, that makes sense. So Guy, Mona mentioned a couple things that have been in the media lately, and that is the issue of access to this safe supply. And in particular, there's been a number of media stories in the last couple of weeks of people in remote and rural communities in particular who are saying they're having difficulty accessing that. And is that because healthcare professionals in those communities are struggling themselves to write the necessary prescriptions to provide this kind of access?
Yeah, I mean, unfortunately, I think, doctors are trained in their scope to be, do no harm, and they believe that they need evidence that proves that it wouldn't cause harm. But unfortunately, when you're in an emergency or a public health emergency, um, you gather evidence. The evidence is clear. The drug supply is contaminated. Not prescribing safe supply is actually doing more harm, and not just the sense and the harm of the street drugs, but also what people have to do in order to get their drugs. If you could reduce those risks, such as survival, sex trade work, criminal behavior, if you can reduce those behavior patterns in people's lives, then that's the part of the what you have to do to get the drugs is the shame and guilt that keeps you trapped. But if we can alleviate that through prescribing, it actually reduces more harms by actually giving people the ability to move forward with their lives and do other things where they don't feel so hell bent on self-hating themselves. Because I went through that for a long time in my life, and it's really the action that keeps you trapped, what you have to do to get the drugs. So a doctor to prescribe would actually reduce numerous risks. Not only that, but what keeps people trapped in that vicious cycle. And eventually, what comes with that is, overdose or death.
Yeah. Okay, that makes a ton of sense to me, in particular as a healthcare professional. I absolutely get that for sure. I guess, I know some of the media stories around difficulty in accessing have related to physicians feeling like they're putting themselves at risk from a liability perspective. And I think the part they don't get, and this applies to pharmacists as well with regards to dispensing these supplies, is that not making the supply available and leaving the person themselves to then access what they need through the street supply, which is contaminated, as we've been talking about, probably has as much, if not more, liability associated with it than prescribing the safe supply in the first place. Do you want to speak to
And
that,
it
Mona?
goes back to legislation. It really does go back to legislation because safe supply right now is housed in a medical model. But again, going back to legislation, that maybe there should be another look at it because again, this is one method of looking at safe supply, and it really, really, really does speak to the fact that our province and as well as all the other provinces around. Canada, there's a long-standing gap in our addiction system of care for sure, and then this is just exposing it more now in terms of accessibility.
For
I'd
sure.
also
Guy, did you want to add something? Yeah, go ahead.
Yeah, I'd also add in, though, unfortunately, how the structure works is we meet the College of Physicians and Pharmacies where they're at, and we're not meeting the substance users where they're at. And that's the piece that really needs to change moving forward because it's about really looking at human lives that are not just impacted in the downtown east side, but right across the whole province. And then, until we all show transparency and work together, we're gonna have these power struggles and issues, and it's truly the reason why it's so complex right now. We need to all work together to change this because we all have to play a part in this.
Yeah, and I read an article today, sort of shifting gears a little bit, but with regards to the guidelines themselves and the fact that maybe they don't go far enough because they're only really dealing with oral solid dosage forms and not providing. We don't have the tools necessary to allow the prescribing of injectables, and so we've got this bit of an issue which has risks associated with it of folks injecting crushed tablets as opposed to actually being provided with an injectable. So what's the what's the barrier there, and what's the solution? What do you think, Mona?
Well, there's a lot of barriers with legislation. There's a lot of barriers, as what Guy pointed out, not enough prescribers and pharmacists trained up to provide some of the addiction treatment care. Studies for for safety, legislation for sure, and that decriminalization and bringing product in, because as well, you may know that there is a heroin injection site as well, where there is heroin
Yes.
provided. Um, and that speaks to the need, right? Where there's people lined up waiting, and I can speak to this too, to get into a program, but there is not enough slots at all, and not enough spots for individuals that are seeking care.
Yeah, I think I read that there's only 160 people on that particular program, and I know the product is being imported from Switzerland, I believe, and so the question becomes, what needs to happen to broaden access to that particular program? Guy, do you want to weigh in on this?
Yeah, for sure. I mean, I'm in talks with Health Canada all the time, and I've told them the solution. The solution is create a domestic supply here in Canada, but also going back to, we already have structurally the programs in place here. We just don't have the drugs or access to the drugs, such as we're giving people those crushed pills, and then people are saying like, oh well, they're crushing them. Then it has these risks. Well, or it's diversion. It's like, no, pick one, because you can't pick both. If you're going to give people the pills and then complain that they're crushing them, injecting them, and then it can cause all these health issues, then isn't it simplified as trying to give them the liquid hydromorphone, talking about lowering the cost of it so that it benefits everybody? But structurally, we have all these programs already in there with the eye out and the tie out programs. We just need access to the drugs, and somehow, some way, I think when you look at the sheer numbers of 170 people dying in 1 month, what does it take for that to move? Is it 200? Is it 300 people? Like, I mean, does somebody have a number in their head that they're not saying? Is it take that much to actually move the needles that we can actually give people a safer supply? In a way where it's not blanketed, it's individualized. If somebody comes in and they're using a certain drug such as fentanyl, then isn't it more sensible to say, create a model that has fentanyl, diacetylmorphine, and then when somebody's on fentanyl, you could wean them down to diacetylmorphine, and then if they wanted to get on Suboxone, and then if they wanted to go into recovery, we need, this is the model that could exist, that needs to exist in order to transition people to improve the quality of their lives. And until we actually get to a place that happens, sadly, we're going to lose a lot more lives.
Yeah, and it's, I get the issue, which has also come up, and I think you've referred to this yourself, Guy, is the issue of comparing this pandemic to the COVID-19 pandemic, for example, and looking at, we've had more deaths in the month of May from overdoses than we have in the entire time that we've been in the COVID-19 pandemic in the entire province of British Columbia. I think we've had 167 deaths since the pandemic was declared for COVID, and we just, as we said, 170 deaths just in the month of May alone. So why, I guess the question is, why are we as society devoting so little resources in relative terms to this pandemic versus the COVID-19 pandemic? Mona, what do you think?
I think personally, society believes that people are choosing to use substances. And with COVID, there is no choice. I really believe that deep down inside, nobody's ever told me the truth. I'd appreciate some honesty from somebody in the meetings that I have, because then I could actually say, at least we're getting somewhere. But instead of making all these other excuses up of why it's not being done, but it's one of the things that I've definitely thought of. People for many years said I was choosing to live. Nobody chooses to have trauma impacted in their life, or be homeless, or suffer in poverty, or suffer through substance abuse. It's one of those things that once it takes a hold of you, it's really challenging to break free from. And believe me, every day I understood the self-hatred that I had in my own life. And it was like punishment from how people viewed me in society and how that trauma, trauma is the motivating factor in addiction. Then why would we impact people with more trauma? New trauma brought on relives old trauma. And I mean, I just had this vicious rolling cycle that was like to the death of me. And it was extremely challenging. So until we get to a place where we actually look at the value of human life and stop focusing on the addiction and start looking at the story behind it, we're going to have these kind of conflicts with people. It's not a choice. I didn't make the choice to have my life go that way. Yeah, I made the choice at 12 years old to start using substances to address the trauma that I was enduring. But if you endured the trauma that I did, you'd probably be picking up substances yourself as well.
Yeah. Mona, do you want to add
Well,
anything?
not a choice at all. It's important to support patients, our community. We're starting to look at it with some of the education offerings for pharmacists to expand out the knowledge of opioids, of trauma-informed care, of the opioid use disorder, alcohol use disorder, etc. It's a start. It's not enough. It right now you can see it like 170. That's not acceptable. It isn't. We need to do more. We need to educate our own profession more, everybody more, not just professionals, the stigma around family, everything, in order to help the care of everybody in our community, in our province, in Canada, because everywhere it's rising a little bit right now.
Yeah, you just said a couple things that really struck home to me, and I was going to interject those into the conversation after Guy responded to this question, and that's the whole issue of education. And I think you're right. Educating healthcare professionals that are sort of on the front lines and having direct interaction with folks who have these issues, makes a lot of sense. But we need to go way beyond that. We have to find a way, I think, to educate society in general, so that we can get to a point where the stigma starts to become non-existent and removed. And it's just there's too much stigma associated with it now. As you said, Guy, that's why you can't really get an honest answer when you get engaged into terms of what these programs look like and are we headed in the right direction and what's the way forward. So let's shift gears a little bit for the last couple sort of topics here. The first one I want to ask about is, and you can both weigh in on this, maybe you start, Mona, is, we've got a lot of things going here, and we're talking about the issues with those programs in terms of whether they're working, whether they're not, or whether they provide enough access, or whether enough folks can access them. But how does that stack up to what's going on in the rest of the world? Are we doing an okay job relative to other jurisdictions around the world, or are there other models that we can learn from? What's your take on that?
Well, we're always looking at different models. BCCSU, for example, where I work in, we do look at different models. We have a lot of connections with other places as well. But Guy can speak to more in terms of, as a peer, a navigator as well, what's available out there. I know I've listened in on what's available in other countries, and we are ahead of some countries for sure. We're not ahead in some of the legalization, right? We're not ahead in some of the decriminalization. Right. Which is a totally different topic that needs to be addressed, because it is that elephant in the room, shall we say, that can address a lot of these issues, that can help a lot of individuals too. But again, that's a different level of conversation within the own federal government.
Yeah, Guy?
Yeah, I think, I think we have, I don't judge success on a little few research projects that we have going. For me, it's about lives, and that's the bottom line. And we haven't reduced any lives. 11 people die in Canada every single day. And until those numbers, for 20 years when I used heroin in the downtown east side, I never overdosed once. And when fentanyl hit the street, I overdosed 6 times. That just shows you just how devastating this thing has taken over. That you could actually live a normal life, if somewhat of a normal life, by just using heroin for 20 years. And then fentanyl comes in and you're annihilated within 9 months. I'd overdosed 6 times. And so,
yeah.
For me, 4 people a day, every day in Canada is just, I mean, in British Columbia is just, it's heartbreaking. And for me, until we get those numbers down to where it was for the last majority of 10 years, which was, roughly 215 to 220 people a year, people are going to die using drugs. That's just part of it. But they're not 10 times or 8 times that amount. It's completely unacceptable. And so for me, the bottom line for me is that we're not doing, nearly enough until we can bring those numbers down. And somehow, some way, we all have to figure out a way to do that.
Yeah, for sure. And Mona, earlier you said, well, 170 is not acceptable, and you're right, but 1 is not acceptable.
No, it isn't.
From a
Because
broader
why we have
perspective, we should have a program that provides an opportunity for every single person who has an addiction to be able to access the resources they need to move their life forward and be safe, for sure.
And
So
it's heartening to see that, because we have patients that we know the same thing. We see them, everything was good, and then something happens, right? And they're not with us anymore. So it is very traumatizing to everybody, that these
yeah.
individuals had a right to live.
So give me a word or two here, Mona, for pharmacists who are watching, because by the nature of our program and our podcast here, the majority of our audience is pharmacists. So speak to the pharmacist audience here in terms of what they need to do around education and their involvement in helping folks navigate to the resources they need to both access a safe supply and move forward with their lives to other therapies or support mechanisms that might be available to them.
I always say, like, not everybody is out to trick you on a medication or a prescription. It is really important to look at the person. It's a person that needs help. If you yourself are not really understanding why certain medications are being written, for example, just reach out, because sometimes there's been so many information surges and information in emails with the COVID, with safe supply, with different changes in coverage, that we might miss something. And if something doesn't make sense, definitely reach out to understand what is needed for that person, because it can be any drug. It doesn't have to be an opioid drug. It can be, diabetes drug. So treat everybody the same is what my message is.
Guy, do you want to say anything about that?
Just have some compassion towards people that are struggling, and do your best to be an advocate for them. Somebody comes into your pharmacy, and doesn't have a prescription per se, but, needs some help. Maybe try to work with them, contact a doctor, see what you can do. I think it's time that we start advocating for the people that are most vulnerable, and that's the drug users that are dying at a rapid rate. And if we can do that, we can change anything.
Yeah, well stated, for sure. I think you're right, Mona, in terms of education. There's lots of programs out there that can help pharmacists become better at helping patients navigate these kinds of issues and navigate the system, if I can put it that way, to the resources that might be available to them. But that's only going to work if, as a particular individual, they have the compassion and empathy that they need to be able to engage with these people in the first place from the right perspective. And we've seen all this stuff in the news lately, and all of the protests in the United States around Black Lives Matter and All Lives Matter, with respect to systemic racism. I think in society, and even in healthcare professionals and in the medical profession, the pharmacy profession, we have some issues with, I'm going to call it a systemic profiling of people based merely on their personal circumstances, which unfortunately I think is leading some healthcare professionals to not act in as compassionate and empathetic manner as they could to really help these folks, and not recognizing what kind of a difference they really could make in somebody's lives if they just approached it from a different perspective. Does that make sense to you guys?
Totally
Yeah.
I'm
makes
getting
sense.
nodding. Yes, it's good. Yeah.
You
So we're
saw
going to wrap this. Yeah, we're gonna wrap this up, but I think what we've uncovered here is the need for, a lot more conversation, the need for all of us to do whatever we can around trying to educate society in general overall around what these issues are, why they exist, and how we can overcome them so that we can remove the stigma associated with them. I mean, for many, many years, we had a significant amount of stigma associated with mental health, for example, in society. And I'm not saying that's totally gone, but I think from my perspective at least, the stigma associated with mental health issues is starting to wane. People are starting to get that. And we sort of need to find our way to that same place with regards to addiction issues, for sure. I think we've made some good strides from a pharmacy perspective. We've got the opioid agonist, a training program that's available. That's a requirement now for all pharmacists in the province that are going to be involved in dispensing of opioid agonist therapy for patients. And I think that's an important step, but there's lots of other things we can do. So let me just close by giving you each an opportunity to say anything that you want to say that maybe we didn't cover today through the interview, and hopefully we can have you back. So Mona, let's start with you. Anything you want to add to the conversation before we wrap up?
No, it's just listen more to your patients. And also be aware of peer navigators. If peer navigators come to you on behalf of a patient, they're there for a reason. They're there to help that patient in front of you. They share a patient or a client with you, because that's something that I've learned over the years with meeting a lot more of the peer navigators from either the HIV crisis or now with the opioid crisis.
Yeah, that makes a lot of sense to me. And I know as a pharmacist myself, had I known of folks like Guy, for example, and how to access contact with someone like Guy, I think it would have made my job a lot more fulfilling and a lot more meaningful and a lot better in terms of how I approach things. And it's something that I know when I was working in a pharmacy, I was unaware of those kinds of resources. Guy, let me give you the last word here today.
Yeah, just to echo what everybody's just said here, there's many drug user groups that are out in the community, especially if you're in Vancouver, or there's the provincial BC Drug War Survivors. They have a website, Vandu or Solid Outreach, depending on where you are in Victoria. They're a great resource for people that are struggling and could possibly navigate some of the services that people are having challenges with. So keep that in mind. Keep it in your back pocket as a possibility. They love working with anybody in the community, and especially when it comes to helping a person that uses drugs. So one great, three great organizations to contact.
Terrific. Well, thank you very much, Dr. Mona Kwong and Guy Felicella. We appreciate your time today. I hope that to our audience, I hope you find this informative, useful, educational, particularly the pharmacists in the audience. Feel free to reach out if any of you watching or listening today to this episode want to contact Dr. Kwong or Guy. Let me know, and I can certainly put you in touch with that. So again, thank you for tuning in, and we hope you enjoyed this episode of Pharmacy in Flux, and we look forward to welcoming you back for the next episode. Thanks.
Thanks a lot, everybody. Have a good day.
Thank you. Bye.